Yeah. Um, okay. So when I was looking through this chapter and thinking about our quiz, I really found Archer very helpful, especially for electrolytes, because they had a lot of shortcuts on how to memorize all of the different symptoms that you can get with the different electrolyte imbalances. So I found that particularly helpful, and I'm going to use the way that they taught it for the way I'm going to like review it. Um, and I also feel like since we have so much time till our quiz, if we can just get at least one subject down where we feel like I feel really good at something, um, I think that'll help with like studying since it'll be one less chapter that we will have to worry about. Um, but one of the things that I really wanted to start with is like the different types of electrolytes. I know she did put an emphasis on like the different types of cations and anions. For me, the way I remember it is just pretty much every electrolyte except for chloride and phosphorus, which are one of the two that we talk about for electrolyte imbalances, are negative, where everything else is positive, like sodium, potassium, calcium, magnesium, hydrogen, all of that is positive. Whereas chloride and phosphorus are the only two electrolyte imbalances that will be negative. And bicarbonate is also negative. So that makes it an anion. Um, Something else that I wanted to go over was the lab values because I wanted to make sure that we all have the same things in our notes. So for me, for urine specific gravity, I have the Dr. Remy said it's 1.003 to 1.030. And for urine osmolarity, I have 200 to 900. For the BUN, I have 10 to 20. And for creatinine, I have zero point 0.7 to 1.4. Is that what you all have? I just want to make sure that we have like the same values.
Yes.
Okay. Okay, cool. Um, so that's what I have. I also have that she said for hematocrit is 35 to 45%, and that um CVP, which I think is central venous pressure, is 8 to 12. So those are the values that I think are most important and we may see a lot, especially if she gives us practice questions or when we take our exams. So I wanted to put that more in the beginning so that we kind of have like that foundation. Um, the next really important thing that I want to look at is the crystalloids or the different types of fluids. So we have isotonic, hypotonic, and hypertonic. And what's really great about isotonic solutions is that they don't really move fluid between the compartments, meaning between intracellular and extracellular. It's pretty good with keeping fluid where it's supposed to be, except Dr. Remy said for isotonic that 5% dextrose in water, when it goes into the blood, the sugar can begin to crystallize and it can cause edema. So that's why we have to be very careful with D5W. But for 0.9% normal saline and lactated ringers, it's not really the case. For hypotonic, and hypertonic, we are doing shifts. We're moving fluids somewhere. So for hypotonic, it's really great for something like hypernatremia or high sodium levels because um, imagine with like a cell that gets a lot of salt on it, right? It's going to be really shrunken and shriveled, but the hypotonic solution is actually going to fill up that cell. So instead of it being all like shriveled, it's going to actually blow up, kind of like a balloon, right? You have to push air into it. That's kind of what hypotonic does for the cells when we have hypernatremia. And I think of that as anything that's almost half of those regular isotonic solutions, which pretty much really helps me identify which one is what type of fluid. So if I see like 0.45 normal saline, I know that's half of isotonic, so I know it's hypotonic. Um, And another example is 2.5% dextrose in water and 0.45% saline. For hypertonic, um, we usually give this to a patient who has hyponatremia. And the way I think of this cell is that imagine it's like a balloon again, right? And it's blown up really big, like really, really big, and it looks like it wants to pop. So that hypertonic solution sort of blows out some of that air to get it more at a normal level. So that's what hypertonic does for the cell. Um, when we're talking about hyponatremia. So examples, I just think of anything larger than isotonic. So 3% normal saline, 5% D5W, 5% normal saline, 10% D5W, anything just larger than isotonic. That's kind of my reference that I use when I look at how do I know which fluid is which. Okay, so then after that, we have problems with fluid, right? Or fluid imbalances. So, we have fluid volume deficit, which is not the same as dehydration. Fluid volume deficit could lead to dehydration, but it's not the same thing. So basically, when we have um, fluid volume deficit, we are talking about losing more water than we have in our body. That's why we call it fluid volume deficit. We are losing a lot of our fluid, and in return, we can also be losing electrolytes. Whereas fluid volume excess is just having too much. So we're intaking more fluid than our body needs, and we can't excrete all of that fluid properly. So that's like the main difference between the two. So, I'm a chart lover. I like charts. So, after I go a little bit more into detail in these two, I'll show you my chart, um, for comparing the signs and symptoms of fluid volume deficit or hypovolemia and fluid volume excess or hypervolemia. So, as I said, um, dehydration and fluid volume deficit, not the same thing, though it can lead to that because dehydration is just loss of water, whereas fluid volume deficit is not just water. It's a bunch of different things, including things like electrolytes. So, um, now if we're thinking about, okay, there's a problem with fluid in our body, right? Something is causing us to lose more fluid, um, making it inadequate for our needs. So we're looking at things like, okay, abnormal fluid losses like vomiting, diarrhea, sweating, GI suctioning, all of that can make you lose more fluid than you're supposed to. Not good. That's why they emphasize, right, drinking Gatorade if you have a stomach bug and drinking lots of water because you don't want to go into fluid volume deficit or become dehydrated. If you're not drinking enough, right, you're not drinking any sort of fluids or enough fluids for your intake, that can also cause fluid volume deficit. Now, something that we'll also see in shock, right? Because fluid volume deficit is hypovolemia, but there's something called hypovolemic shock, which is what happens when we have so much loss of fluids that our body and our organs could start shutting down, and that becomes a problem because shock is basically when there's a lack of perfusion to our vital organs. So an example, burns, even though burns can cause hypovolemia, it could also go into hypovolemic shock depending on how bad the burns are. That's why I just wanted to emphasize that. Because hypovolemic shock just simply means you lost so much fluid that now your organs are having a real problem. So that's why fluid volume deficit can be very scary. Um, we also have adrenal insufficiency because then we're talking about some of those corticosteroids, um, and that plays a big part in our sodium and water retention as well as hemorrhaging. Okay. Um, so we also know that for our older population, right, one of the most important things is that as you age, right? Their skin elasticity and everything starts to slow down. So you wouldn't really be able to do a skin turgor test on our older adult population. It really wouldn't make sense because their skin isn't as strong, is the word I'm going to use, as ours. Um, but for these, we really want to watch for daily weights and INOs, especially because daily weights are the best indicator of hydration status. And if I had a question on the quiz, if it would ask me like which would be the best way or most effective way in managing fluid volume excess or anything really, like fluid volume excess or fluid volume deficit, I would pick daily weights. And that's because if you lose a certain amount of pounds, let's just say 3 pounds in a day, that means you're losing a lot of fluid. Something's leaving your body. If you gain 3 pounds in a day, that means you're gaining a lot of fluid. So that's why weight tells us a lot about the patient. Other ways that we can manage fluid volume deficit include INOs, pulses, um, hourly urine output. And that's because, right, if we don't have enough fluid, they're not going to be peeing as much because they don't have anything to really pee out. Um, and as a result, remember, we can go into hypovolemic shock. So if we don't have enough circulating fluid, that will cause our blood pressure to drop. And as a compensatory mechanism, our blood pressure to go high. So that's why we look at our pulses. We look at vital signs, their mental status, confusion can often be something that we see when we have fluid volume deficit. Um, labs, right, which we'll get into a little later about the lab values and all that. We're also going to need to look at fluid replacement, right? Because we said a potential problem of fluid volume deficit is sorry, is hypovolemic shock. So it could get to that if they don't get fluids in enough time. Like I said, our goal is to give them isotonic solutions like lactated ringers or 0.9% normal saline, just because it doesn't do as much fluid shifting. We talked about skin assessments, we talked about ways to minimize fluid loss, right? Such as taking care of yourself, especially when you have just say a GI bug, because that especially can cause problems with abnormal fluid losses, fall precautions because of orthostatic hypotension that we can get from fluid volume deficit, things like that. Sometimes, though, it can feel like a lot to sit there and say, oh my God, I need to know all of these like nurse management things. I wouldn't personally do that. I like to think about the symptoms and think about how I can manage those symptoms. That's why when we get more to the chart, I think it'll make sense. Um, Hypervolemia or too much fluid means, okay, we're keeping things in our body that aren't being able to come out. And this can cause problems with the heart, the kidneys, right? Because it's going to start causing pressure buildup and make those organs work harder, especially our heart and especially our kidneys and other places if the fluid continues to stay. Now, just like with fluid volume deficit, right? You look at your electrolytes, you're looking at your BUN, you're looking at your creatinine, your hemoglobin, hematocrit, because it's going to be a lot of the same indicators um, for these things in terms of, okay, we're looking at the same like sorts of electrolytes, same sorts of lab values. They're just going to represent slightly differently when we're talking about one versus the other. Urine specific gravity, osmolarity, and chest x-rays, especially for our fluid volume excess patients. Why? Because if that fluid builds up so much, they can have crackles. So that's not good. Diuretics would be great for these patients because we can remove that excess fluid, but these would be terrible medical management for someone with fluid volume deficit because they don't need to remove any more fluid. They need to maintain and keep fluid. So with fluid volume excess, it's the same sort of management that you see with fluid volume deficit with daily weights. Remember, that's the best indicator of hydration status. Um, INOs, right? We're going to look at their skin, all of that stuff that we said, labs. But the difference here is that we're also going to add for nursing management for fluid volume excess is the lungs and specifically looking for edema. as well as fluid restrictions, right? Compared to fluid volume deficit, they need fluid. Here, they don't need fluid. They have enough. They just can't get rid of it. So, diuretics are going to be our friends here for fluid volume excess, but they can cause electrolyte imbalances. So it requires a lot of monitoring. So I have a chart because I love charts and I like looking at things side by side. It's just something that makes studying a lot easier for me. So, like I said, for me, I don't try to memorize the management of all of these things. I try to think about, okay, what are my signs and symptoms for each, and what would I do for each, right? Like, for example, in fluid volume deficit, you have tachypnea, right? Rapid respirations. Why? Because they're losing fluid, right? Their heart rate is increasing because their blood pressure is dropping because of the inadequate fluid. So they're probably feeling a little anxious, and that tachycardia can lead to the tachypnea, and that's why they're breathing really fast. Something with this is that they're also going to have a rapid, thready pulse. So it's going to be kind of weak but feel quick. And that's because, right, the body is trying to compensate for that lack of blood pressure, but it's not going to be as prominent as if this were a normal patient with normal fluid balance because they don't have that right now. Um, Also, weight loss, right? We talked about weight being the best indicator of hydration status. Weight loss is something that fluid volume deficit has. They are losing too much fluid, which could eventually lead to hypovolemic shock. Dry mucous membranes don't have enough fluid. Orthostatic hypotension, the blood pressure drops. Now, for fluid volume deficit, the lab values are going to increase. Hematocrit, hemoglobin, BUN, creatinine, urine osmolality, urine sodium, urine specific gravity. Because imagine, right, the cells not getting what they need, and that hematocrit and hemoglobin are going to increase as a result of not having enough fluid. And the BUN and creatinine are going to increase because potential problem is that the kidneys aren't functioning properly because of the lack of fluid. And the urine specific gravity, the reason why that goes up, because whatever they're going to pee out, which isn't going to be much, but when they do, it's going to be very concentrated because they don't have much fluids, but whatever they do have, they're going to try to get out. So we already said they have low BP, they're going to have cool skin because of that lack of perfusion. They're going to be confused, weak, and their capillary refill will be greater than 3 seconds. Dr. Remy also noted that late signs of fluid volume deficit include oliguria, which is urine output of less than 30 ml per hour, a flattened jugular vein, and that CVP, that 8 to 12 number, is going to decrease. So when I look at this, I'm like, oh my God, that's a lot of symptoms. But if I know fluid volume deficit, I know fluid volume excess because it's the opposite, right? So instead of having tachypnea, they have bradypnea, they have crackles, not tackles. They have crackles because they're having fluid in their lungs. Their pulse is bounding because of all that extra fluid. They're having tachycardia as actually compensatory, and as well as that pulse being so bounding, it's also going to affect the cardiac output and make them have an increased heart rate. They're going to have weight gain because of the fluid building up in their body, which also will eventually lead to edema. Now, the lab values decrease instead of increase, like in fluid volume deficit, because it's, imagine just having so much fluid, more than you need. Everything's sort of going to be like, um, it's going to have so much more than it needs that it's going to cause everything to decrease. Like the kidney function is going to start to overcompensate, and that overcompensation is going to cause the BUN or the BUN and creatinine to start going down. That urine specific gravity is going to go down because they're going to be peeing out so much that there's not going to be as much concentrated substances in their urine as there normally would be. And imagine being so much more fluid in those red blood cells than you need, it just swelling more and more than it has to. The hematocrit and hemoglobin are going to start to decrease, almost like if it's being overhydrated. And that's the reason why those values start to go down because they don't need to be as high. Um, and the CVP is going to increase. There's going to be their jugular veins are also going to be distended because of all that extra fluid and have a high blood pressure. So if you know one, you know the other because it's going to be the complete opposite. Um, is there any questions on anything that I just said?
No.
Okay. So yeah, like I said, I love the chart. I think it's so useful because I like looking at symptoms and things like that side by side. So, the next thing I do, and I will clarify with Dr. Remy, is the electrolyte values, just because our textbook and her slides are slightly different. So I just want to make sure that all the values are the same. But for what I saw based on the slides was that sodium is 135 to 145, potassium is 3.5 to 5, chloride is 97 to 107. I think our textbook said it was 98 to 106, so I definitely want to ask her that. Bicarbonate should be 22 to 26. Um, the slides said 8.6 to 10.2. I think our textbook said 8.6 to 10.5. That's why I just want to ask, but I don't think they'd make it that close. Like, I think if she were to give a question, it would be like calcium of 7 and a calcium of 11, even though it's so minute. I just want to make sure. Um, for phosphorus, it was 2.5 to 4.5. And for magnesium, it was 1.3 to 3, but our textbook had 1.8 to 2.9. That's why I will clarify which values she wants us to look at. But regardless, that's what the slides say. So those are the ones I'm going to go by. So hyponatremia. We already said for this type of electrolyte imbalance, we give hypertonic, like I was talking about the balloon idea, right? This balloon is so swollen, this particular cell is like really, really puffed up that hypertonic solution is going to blow out air from that cell to make it more normal. So, um, for sodium loss, right? Um, a mnemonic that I saw in a book that I used said salt loss. So the S stands for stupor or coma. Uh, A stands for anorexia. The L stands for lethargy or like confusion. The T stands for tachycardia. Um, L stands for limp muscles. The O stands for orthostatic hypotension, seizures, and stomach cramping. Now, I think like mnemonics can be helpful, especially on exams. Like you could like list out like what each letter means, but there is a few that are more important than the others. So, like for example, for salt imbalances, what I was learning from using Archer is that neurological status changes are the most important thing with sodium, both hyper and hyponatremia. They both can cause seizures. That's one of the priority things that we want to look at when we have a patient with a sodium imbalance, regardless if it's hypo or hyper. Now, for hyponatremia, right, we're talking less than 135, we could also see stomach cramping, lymph muscles, confusion, and tachycardia. The reason I mention that is they have seizures. They can also, a pre-warning sign could be, hey, they're starting to get confused, right? And tachycardia, because of not having enough salts in those blood cells, things start to get moving. Things need to increase to compensate for not having enough salt. Um, Also think about it, if you don't have enough salt, right? Your blood cells and your blood can't really function properly. So things are going to start to decrease. Things are going to slow down, like decreased blood pressure, um, slowed neurological status, meaning confusion, abdominal cramping because not having that electrolyte. But the main thing is, like I said, those seizures. And Dr. Remy did point out that low sodium levels can also cause fluid retention. So I would also keep a note out about that. But some of the things that I've seen a lot being asked with sodium has to do with neuro, has to do with seizures. But this could definitely be a great like little mnemonic for the test to help you remember like other signs and symptoms of hyponatremia. So, right, we have an imbalance of water, which is one of the reasons why hyponatremia happens. It could also be caused by vomiting, diarrhea, sweating, diuretics, adrenal insufficiency. Because remember, I talked about those like corticosteroids that the adrenal glands make. Um, SIDH, which is like something insufficient anti-diuretic hormone, um, and things like that. So, um, there's different reasons why you can have hyponatremia, right? It could be a medication, it could be vomiting, right? So we definitely want to make sure that we treat whatever that is, right? If it's vomiting and diarrhea, we try to stop that, right? If it's um diuretics, let's see if we can, change those medications and notify a doctor that this is happening, things like that. Another thing is water. Restricting water, especially tap water, is really important because the more water that you keep giving them for someone who is hyponatremic, the more diluted those cells become because they're over being hydrated, that the salt level is just going to continue to decrease. So we don't like to give water as a fluid replacement for someone who has hyponatremia. We want to give a hypertonic solution as the fluid replacement, um, such as 5% sodium chloride. So we can give them that, but not water. Weights, inos, you could just remember for any fluid and electrolyte, any imbalance that has to do with that, you're going to include weight and you're going to include INOs, lab values, and you're watching out for that neurological status. You're watching out for seizures. That's one of the most important things when it comes to sodium. And, if they're on diuretics, think about that when we're looking at the lab values. Now, hypernatremia, as I said, neurological status, whether it's hypo or hyper, we're talking about seizures as a problem. Okay. Now, another little mnemonic that I saw for hypernatremia was something called fried salts. So it's flushed skin, they're restless, anxious, increased blood pressure and fluid retention, edema. You could also think of it as where salt goes, water goes. So if you have more salt, and let's just say you're drinking a lot of water, they go together, that can cause fluid retention. Um, Decrease urine output. Um, the skin will be really dry, right? It's like if you eat something so salty and sometimes your mouth gets dry, think about something like that. A swollen, sticky tongue, um, a potential fever, and seizures. But the ones that are pointed out by Dr. Remy slides are thirst, right? Because all that saltiness, imagine eating something really salty, it makes you really thirsty, an elevated temperature, and seizures, 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 seizures. Now, fluid volume, fluid volume deficit could actually be one of the causes for hypernatremia, right? If we're having a lack of fluid in the body, we could also, as a result, have a higher um, sodium level. So, and it kind of makes sense when you start thinking about, hey, lab values start to increase when we have someone who has FED. Um, so, sorry, I don't know. I think I just said something that's confusing. I meant to say that when you have fluid volume deficit, all of the lab values do increase. That is true. So we can also see potentially, right, hypernatremia, salt increasing. So we just need to be careful with that too. Um, Excess sodium administration, right? If they're just either in their diet or if they're getting too much, such as say sodium chloride, that can cause it too. Diabetes insipidus, I just want to explain, it basically means that there's not enough uh diuretic hormones, so they pee a lot. So because they pee a lot, um, it can also cause sodium imbalances. I just wanted to kind of explain what that is. And our hypertonic solutions, right? We use that for hyponatremia, but they have high levels of sodium. So giving someone who has hyponatremia a hypertonic solution can cause hypernatremia. Um, so yeah, management, right? This is someone who has too much salt. So obviously we're not going to try to give them more salt. We're going to avoid that. We're actually going to give them hypotonic solutions like 0.45% normal saline or sodium chloride. Um, we want to be careful for abnormal loss of water, low water intake, um, those CNS changes, and seizure precautions. Okay, especially for salt patients, like patients who have sodium or salt imbalances need to watch out for seizures. Um, okay, so for hypokalemia, right, we're talking about potassium. We're talking about, okay, 3.5 to 5. So the most important thing, I think, when it comes to the potassium is those EKG changes. And Dr. Remy emphasized EKG changes, dysrhythmias, muscle weakness, and something else that I commonly see asked about when it comes to potassium is the decreased bowel motility. So she said for us to look out for a peaked P wave and a flat or inverted T wave on the EKG for hypokalemia, whereas hyperkalemia is going to be a peaked T wave um, and a flat P wave. So you could just think if I know one, I know the other. So for hypokalemia, vomiting, right? GI suctioning can remove a lot of electrolytes and can cause hypokalemia. Um, an acid-base imbalance, right? Can most definitely cause that. Hyperaldosteronism, because hyperaldosteronism means that we have so much salt. When salt usually increases, potassium decreases. So they have like an inverse relationship. Um, Diuretics, and as well as metabolic alkalosis. Now, things that we need to do for someone who has low potassium? Well, one, right, we have to check the levels before we give them any sort of potassium supplements, right? Because if it's normal, we're not going to give them anything. But if it's low, then yeah, we're going to give them that potassium. Potassium replacement, right? Obviously, if they have low potassium, we need to replace the potassium, whether that's through an IV, whether that's through supplements or increasing their dietary intake, things like that. But our priority when it comes to someone who has hypokalemia is EKG changes. We'll look at ABGs, we'll look for signs and symptoms, right? Like muscle weakness, things like that. We also want to watch for patients who are taking digoxin because digoxin toxicity increases when you have electrolyte imbalances like hypokalemia. So that's something else that we have to be really careful for. Um, and yeah, but the priority here for hypokalemia is those EKG changes. Same thing for hyperkalemia. The priority is looking at the EKG. Um, this one actually also has a mnemonic when we have potassium greater than 5. Um, it's called murder, which is muscle weakness, urine abnormalities, respiratory distress, decreased cardiac contractility, ECG changes, and reflexes increase. But like I said, our priority when it comes to this electrolyte imbalance is the EKG. So we said in this one we have a peak T and a flat P, which was the opposite of hypokalemia. Now, hyperkalemia can be caused by different things, right? Impaired renal function, because when those salt levels goes down, those potassium levels are going to increase. Rapid administration of potassium, right? We never IV push that, but if you give it too quickly, that can cause hyperkalemia. As I said, with um, aldosterone, we're talking about salt. So if we have low salt levels, we're going to have higher potassium levels, medications like spironolactone, because that's a potassium sparing diuretic, and things like that. So, like I said, our priority, EKGs. We also want to look at labs, INOs, that apical pulse for both hyper and hypo, because there's a risk of dysrhythmias. Um, Whereas, right, if they have too much potassium, what are we going to do? Well, obviously, we're not going to give them more. We're going to educate them on what foods to avoid. And different medications that we can give are IV calcium gluconate, IV sodium bicarbonate, IV regular insulin, um, hypertonic dextrose IV, beta 2s like albuterol, dialysis, as well as Kexalate, which we said we have to monitor bowel movements because the potassium's going to come out. Um, and boop. Um, so yeah, those are the different things that we can give in an emergency if they have hyperkalemia. Um, and one of the medications she emphasized was Kexlate. Now, before I get into calcium, I want to talk about chloride. The reason I want to talk about chloride is because salt and chloride are best friends. So, you ever see like those TikToks where it's like, if my best friend goes, I'm going, or you have one of those friends that's like, wherever she goes, I'm going to? That's kind of what chloride and sodium have. So, when you have hyponatremia, the manifestations are the exact same for hypochloremia or a chloride level less than 97. And that's because they go together. So, right, look at the manifestations. They're agitated, they're irritable, they're weak, they have hyperexcitability of muscles, they have risk for seizures and dysrhythmias. That's exactly the same manifestations that we saw when someone who has hyponatremia. So, um, for hypochloremia, some causes can be like uh, Addison's disease, reduced chloride intake, GI loss, diabetic ketoacidosis, excessive sweating, right? Because sweat causes salt to come out, so chloride's going to come out too, fever, burns, things like that. Remember, salt and chloride go together. So if the salt level is going to go low because of something, um, so is the chloride levels. And I believe someone can correct me if I'm wrong, but Addison's disease, I think, has to do um, with the adrenal gland. Someone can definitely correct me. And I think that's why it has an effect on those sodium levels, which in return is going to affect the chloride levels. So, um, same management, right? No free water, right? For hyponatremia, we can't give free water or tap water. We don't give free water or tap water for chloride. Um, we replace with normal saline, which is sodium chloride, um, for hypokalemia. Um, we are going to encourage foods that have high chloride in them, um, which sounds very similar to what we would do for someone who has hyponatremia. Hyperchloremia is the same sort of thing, right? Looking at the manifestations. Tachypnea, lethargy, weakness, rapid deep respirations, cognitive changes. We also have risk here. There could be a risk for a seizure because we know that if we have hyperchloremia, we also have hypernatremia because they go together. They're like best friends. So that's why it's so important to know if you know one, you know the other. Like, for example, what can be the cause of hyperchloremia? Excess sodium chloride infusions from water loss, because sodium and chloride go together. Hypernatremia can be a cause of hyperchloremia. So you see how um, things just sort of relate. Dehydration, things like that. So our goal here is obviously to reduce the chloride levels, restore any sort of electrolyte imbalance because we know there's going to be a sodium imbalance, and teaching them about diet and things like that. That's why I wanted to mention that before I get into the other ones, because there's also going to be similarities here, but I wanted to express that first. Is there any questions regarding that?
No.
Okay. So yeah, like I said, if you know sodium, you know chloride, which is great because then you don't have to memorize all the symptoms and management for all of them. If you know one, you know the other. Now, calcium is very similar and it actually has a close relationship with magnesium and phosphorus. So, when we have hypocalcemia, we also have hyperphosphatemia because, as we'll also get in when we talk about the pathophysiology, is that hypoparathyroidism causes hypocalcemia, which also causes hyperphosphatemia. Calcium and phosphorus have inverse relationships. But as you're going to see, the signs and symptoms of calcium or low calcium levels, I should say, are the same as when we have high phosphorus levels. So for calcium, we're talking about a level of less than 8.6, and we're talking about this little mnemonic called, I like it, it's called cats go numb. So it's C for convulsions, A for arrhythmias, T for tetany or muscle spasms, um, S for seizures, and numbness. Um, Also, two really important signs that we may see is Chavesky sign, which is when you tap the cheek and it twitches. That's when we know they have hypocalcemia. Or Trousseau's sign, where you put the blood pressure cuff on them and you press it up really high, and then the arm twitches. Um, that is also a sign for hypocalcemia. So we already talked about some of those manifestations. I know we didn't get to it in class yet, but at least we're still talking about it now. This is all copied from the slides pretty much. I've just added a little bit of extra things. So other manifestations, like I said, we talked about tetanies or those muscle spasms, numbness or parasynesthesia, hyperactive DTRs. Now, the reason that's important is because when you have low calcium, it almost causes an excitatory response in the body. It makes you really, really excited. So that's why there's muscle spasms, and that's why they're at risk for seizures because there's an increase in activity when we have low calcium levels. We talked about those signs. They could also have laryngeospasms, right? So we're talking about spasms that are going on in our throat, which can be problematic, and things like that. Now, we already talked about patho, right? Hypoparathyroidism can cause hypocalcemia, but what else can cause it, right? Well, a vitamin D deficiency can cause hypocalcemia, malabsorption, right? If you're not taking enough or the intestines aren't working, osteoporosis, pancreatitis, um, kidney injury, and even medications, right? Like diuretics. Um, so management, right? One of the things that we saw was arrhythmias. So we need EKG. We need to watch out for that. We need to assess the heart rates. We saw seizures in that S. So we need to have seizure precautions for these patients. We want to replace the calcium through oral supplementation and vitamin D supplements because remember, vitamin D increases the absorption of calcium. And a patient teaching on diet and exercise to decrease bone calcium loss. Then we have hypercalcemia. Now, when you have high calcium levels, you have more of a sedated reaction when your calcium's too high. I just want to keep that in mind because you're going to see when we talk about more of the manifestations how that makes sense. So, there's a little mnemonic called BACME, which is bone pain, arrhythmias, cardiac arrest and constipation, kidney stones, muscle weakness, and excessive urination or polyuria. So we talked about some of those manifestations, but there's that muscle weakness, right? And that is in part because, like I said, calcium as it increases is going to cause more sedatory effects. And that also means that, okay, right? They're constipated as well instead of going to the bathroom because that peristalsis slows down. But calcium's in the heart. So also when it's high, causes arrhythmias. Same way when it's low, causes arrhythmias. So hyperparathyroidism is going to cause hypercalcemia, but in return, it's going to cause hypophosphatemia. Um, Immobility, right, can cause calcium to leave the bone and go to the blood, and malignant reasons like cancer. Now, hypercalcemia, right, we're going to reduce calcium intake, right? Fiber for constipation, make sure they're safe because they're going to have muscle weakness, so they're at risk for falls. And we want to lower that calcium level. So we can do that through furosemide and things like that. And you see how there's phosphates there? Because phosphorus, like I said, is low. So if we give phosphorus, if that level rises, calcium is going to decrease because they have an inverse relationship. Now, also, hypomagnesemia is related to hypocalcemia, or in other words, magnesium and calcium have that same sort of relationship that sodium and chloride do, where the symptoms in low magnesium levels are going to be similar to the symptoms of low calcium levels, which is also the same as high phosphorus levels. So look at this, right? If it's like, how do I know like if that's the truth? Well, let's look at the manifestations, right? Chesovic's and Trousseau's signs, they're both positive when we have low magnesium levels. They could be in a depressed mood. They could have neuromuscular irritability. They are also at risk for seizures. They also have EKG changes and dysrhythmias, right? Doesn't that sound like cats go numb? Convulsions, arrhythmias, tetany, spasms, seizures, and numbness? Same thing. And they both have positive Chosovic's and Trousseau signs. Now, also, you can also correct me if I'm wrong, but hypomagnesemia causes torsades de point, which let me just double check. Um, yeah. So, which is basically a very lethal arrhythmia. It's like the EKG almost just looks like a bunch of waves, let's just say, just a bunch of waves. So that's something that we can see as a lethal arrhythmia with hypo or with low magnesium levels, and that's a level of less than 1.3. Now, magnesium is usually related to alcoholism, GI losses, not eating enough, and some medications. But alcoholism is one of the common causes of low magnesium levels. I don't know the relationship between the two. I just know that alcohol and magnesium go together, especially low. So we can give them magnesium sulfate IV to help with that low magnesium level. But remember magnesium sulfate from OB was very depressing. So we have to watch out for those vital signs, urine output, especially respiratory rate, things like that. Um, and seizure precaution, because as I said, it's exactly related to low calcium. So if we know that low calcium, we have seizure precautions, we also have seizure precautions for low magnesium. Hypermagnesemia, which is greater than 3.0, same thing for symptom wise as calcium, and meaning high or hypercalcemia, and the same as hypophosphatemia. So hypermagnesium are when we have high magnesium levels, right? I said calcium is very sedatory when it's high. So we have hypoactive reflexes. Makes sense, right? Calcium is very, when it's high, it's very sedating. Same effects with magnesium. So it causes drowsiness, muscle weakness, decreased heart rate, decreased blood pressure. Even if you can't remember all these symptoms, you could say, you know what? If I know high levels of calcium and magnesium depress the system, I'm looking for signs and symptoms that relate to things slowing down. Both of these, calcium and high calcium and high magnesium, both cause EKG changes and potential cardiac arrest. Same exact symptoms as hypercalcemia. Now, causes of high magnesium levels are excess magnesium intake and even kidney injury and diabetic ketoacidosis. But regardless of how it's caused, we do have to figure out what can we do to help manage this, right? Well, we can give IV, calcium gluconate. Apparently, that's also one of the antidotes that you can give for high magnesium levels that I didn't know. Loop diuretics, right, to lower that. Sodium chloride, lactated ringers. Avoid any medications that include magnesium because their magnesium levels are high, right? Observe for changes in LOC and deep tendon reflex. Because like I said, everything starts to slow down. So we really have to be careful about our respirations and our changes in LOC. And also, like, if when we go back to hypercalcemia, right? Um, we saw that there was sort of that increase in everything too. So we know that muscle weakness can start. So because these are both sedating, we have to worry about respiratory, right? And things like that. So, if we know that magnesium and calcium are very similar, and we know that there's an inverse relationship between calcium and phosphorus, hypophosphatemia relates to hypercalcemia, and it is caused by one of the common causes is hyperparathyroidism or even a vitamin D deficiency because like I said, vitamin D is very crucial when it comes to those calcium levels. So we have to watch out with vitamin D too. But looking at the manifestations, we can see how it becomes related to calcium. We're talking about less than 2.5 for phosphorus. So neurological symptoms, right? Okay. Can cause confusion, muscle weakness. We said that high calcium is sedating. This sounds like sedating symptoms, neurological problems of confusion. Then we have muscle weakness, tissue hypoxia, potential bone and muscle pain because there's a sedatory effect. But I would know one of the most common causes for hypophosphatemia is hyperparathyroidism. In management, right? Hypophosphatemia, low phosphorus, which means we definitely have to replace phosphorus somehow in diet, things like that, right? We also want to monitor vitamin D and calcium levels as well as phosphorus, because remember, they all go together. Mental status, because this is sedatory, so we're looking at, hey, are they having confusion and things like that. Now, something that some foods that I wanted to show as examples that contain phosphorus include like milk, organ meats, beans, nuts, fish, poultry. Also, chocolate, I didn't know that, is high in phosphorus. So they can encourage them to eat chocolate. But here's the thing. Let's just say a question were to say, not talking about hypophosphatemia, but let's just say the question says, oh, my patient is having hypercalcemia. Um, what food should I educate them on? And if it says, oh, tell my patient to increase milk, yeah, they could because that would help with the phosphorus levels, right? But in return, the problem with milk is that if it were to say the opposite, if it were to say hypocalcemia, we really wouldn't want to give milk because it could also increase, because it has high phosphorus levels. And we know that if they have low calcium, they have high phosphorus, milk might not be so good. So that's really important understanding, like, hey, what foods go with what? Because phosphorus and calcium are always intertwined. And that can be tricky because you're like, I'm not even thinking about that. But if I know that in advance, I'm going to look for something that would a patient teaching point or a food education point that would have to relate to both of these imbalances because you don't necessarily have one without the other. You're not going to have high calcium levels without seeing in return phosphorus decreasing too because they just work together. Same thing, hyperphosphatemia, we're going to have low calcium levels. So, in this situation, milk wouldn't be good because it'd be too high in phosphorus. So, we wouldn't want something with that in it. So, usually we see somebody having high phosphorus levels from someone who, has a high dietary intake of it. Um, and the thing that occurs that we will see on an X-ray is that the tissues of the bones can calcify. So basically, there's an abnormal bone development due to this decrease in the parathyroid hormone, because we said hypoparathyroidism can cause um, hyperphosphatemia. So we just have to make sure that we have good, patient teaching points about, calcium in conjunction with phosphorus. That's why all the management says monitor phosphorus and calcium, because you can't monitor one without monitoring the other. And avoid high phosphorus foods, right? Fish, dairy, nuts, milk, organ meats, chocolate. No. Okay. And teach them signs of hypocalcemia. So, like I said, there could be trick questions like that, but you have to think if I'm thinking about calcium, I also have to think about phosphorus. So we talked about chloride. Like I said, I'm not going to really get into that because we already did. And then I'm just going to quickly go over the acid-base imbalances. But is there any questions about any of the electrolytes from before? I'm going to take silence as no. Um, but we have four different acid-base imbalances. So first I'm going to talk about metabolic, and then we can go into respiratory. So with metabolic, whether it's acidosis or alkalosis, the same thing happens, which basically means that if the pH drops, the bicarbonate's going to drop. That's what I mean by same thing, or vice versa. If the pH is high, we expect the bicarbonate to be high. So, like, let's look at an example of metabolic acidosis, right? So, metabolic acidosis has a pH of less than 7.35. That's because a normal blood pH is 7.35 to 7.45. Bicarbonate is normally 22 to 26, but in acidosis, in metabolic acidosis, everything goes low together. So if we have a pH of less than 7.35, we also have a bicarbonate of less than 22. A common cause of metabolic acidosis is renal failure and renal injury. And this can result in also hyperkalemia. Why? Because the sodium levels are going to drop. But if sodium level drops, potassium's going to get high, which means we also got to watch for EKG disturbances with someone who has metabolic acidosis, right? Because of potassium. For metabolic alkalosis, the pH is higher than 7.45 and the bicarbonate is greater than 26. And causes are NG tubing, like suctioning and things like that, or vomiting. And we typically see from this hypokalemia. So for both metabolic acidosis and metabolic alkalosis, we really got to look at our potassium levels. Now, for respiratory acidosis and respiratory alkalosis, actually opposites happen. So for acidosis, for respiratory acidosis, the pH will be less than 7.35, but the PaCO2, because we're talking about respiratory, will be greater than 45. So in a respiratory thing, I'm like, okay, I know if it's respiratory, if the pH and the PaCO2, one goes up, one goes down, and vice versa. Now, typically you will see with respiratory acidosis, hypoventilation. Why? Well, if we have pH less than 7.35 and a CO2 greater than 45, that means we're not breathing off that CO2. We're not breathing hard enough to get rid of that excess CO2, so it stays in our blood. Because PA means like arterial carbon dioxide. So we're not able to excrete it, so we're having hypoventilation. For respiratory alkalosis, we have a pH of greater than 7.45, but a PaCO2 of less than 35, which causes hyperventilation. Why? Because they're breathing so quickly that the blood is becoming more alkaline because the CO2 is low. So that's why we have those imbalances. And interestingly, when you have metabolic acidosis, compensatory, you'll have respiratory alkalosis. And if you have metabolic alkalosis, you'll have compensatory respiratory acidosis. Um, and something else that I've noticed in exam questions when it comes to, oh God, this is confusing. There's so many numbers. Nobody cares about PaO2. Okay, we don't look at that one. I don't look at that one. Never helps me if it's there. Then I say, okay, I look at my pH to see if it's low or higher than the normal range to see if I'm talking about acidotic or alkaline. Then I say, okay, well, you know what? Once I know one, I have to look at bicarbonate and PaCO2. One of those values, there's going to be something wrong with one of them. If it's the bicarbonate, then I know I'm dealing with a metabolic issue. If it's the carbon dioxide, I know I'm dealing with a respiratory issue. I've never really seen questions and even on exams where both of them are out of whack. I've never seen that. But that's why I said like that's a little trick that I use when um I am doing exam questions. So just to like end it off for, the heck of it, just to end it, I'm going to give you an example question, and I want you to tell me if it's metabolic, acidosis, alkalosis, whatever, and why. Anyone could write it in the chat or just shout it out. It doesn't really matter to me, however it's done. Anybody else have any more answers they want to share before I share what the answer is?
Is it metabolic alkalosis?
Yes. Why?
As the pH is high and the bicarb's also high. The pH,
Mm,
PaCO2 is normal, so it wouldn't be
exactly.
respiratory.
hmm That's exact. It can be, like I said, it can be confusing when you see a whole bunch of numbers. But like the way I would like hunch down a question like this would say, okay, well, just as you said it, right? That pH would be, is it higher or lower? It's higher. Okay, so I'm looking at something alkaline. Okay, now looking at the bicarbonate and the PaCO2. Now, PaCO2 is between 35 and 45. So that's normal, which means I'm dealing with a metabolic issue because the bicarbonate is high. And when bicarbonate's high and pH is high, I'm dealing with metabolic alkalosis. And the PaO2 was just a random number I threw in just to look like it's more confusing than what it is. Um, but the main thing is you have to look at what's normal, what's abnormal when looking at these values. I definitely think one of our exam questions will be on how to identify based on their ABGs what they're in.